Test 1 2 1 2. Test test test.
Anytime you want to start, you may have to kind of holler at them to get their attention.
Okay, you want me to go ahead and start?
Yes, sir.
need to make sure his overhead lock.
Let's turn it on. There you go. Like I said, you may want to, wait a minute. They're not going to be able to hear you. I'm going to have to. There we
Okay.
go. There we go.
About this one.
That one's fine. That goes straight to the camera.
Now, right click. Is this what's advances? Okay. All right.
Okay.
Okay, let's go ahead and get started. Can everybody hear me okay? I'm Dr. Hedberg. I'm the clinical director at Bradford Health Services. My specialties are psychiatry and addiction medicine. And we're going to talk about the opiate use disorder problem that we have in the United States. And actually this started back when specifically Purdue Pharma did a survey of primary care physicians, and they asked, would you prescribe an opiate for chronic pain that's not cancerous chronic pain? And the answer was no. We wouldn't prescribe for that. So they went about marketing, and they're the ones behind the fifth vital sign of being pain, and they convinced people that everybody that has pain should have narcotics. And as their oxycodone sold and the prescriptions went up, so did the opiate use disorders and deaths go up. And they did a really good job of marketing. And you can see that the opiate use disorders just skyrocketed along with deaths. And then at around 2008, 2010, boards of pharmacy figured out everybody's getting opiates and they're prescribing too many, and started to clamp down on prescriptions of opiates. And at that point, opiates began to get a little bit more difficult to obtain, and heroin went way up. And that's what we're seeing at Bradford now. We're seeing a lot of opiate use disorders that are both pain pills, but also a lot of heroin. And a lot of heroin, obviously, deaths. And Alabama did a really good job. Back in 2012, we were prescribing about 143 prescriptions of opiates for every 100 people in Alabama. So we got to be number one in something anyway. As you know, there are a number of different types of opiates. The natural opiates all are derived from the poppy seed and were manufactured into different things, codeine being one of the first. Obviously opium that people have abused over the centuries. There are semi-synthetic opiates that start out with the poppy seeds and then get processed to things like heroin and good old oxycodone. And then finally later they developed purely synthetic opiates that were more specialized. For example, methadone is a longer acting. Fentanyl was first developed for anesthesia because it was relatively short acting. And they do a number of different things. All of them stimulate the mu receptor in the central nervous system. The therapeutic uses would be analgesia, obviously. They suppress cough. They can be used as antidiarrheals. The problem with them, obviously, is the respiratory depression. And what us addicts are going for is the euphoria. Now, interestingly, most normal folks, if you put them on an opiate for like post-op pain, most normal folks don't really like how that makes them feel. They kind of feel out of control or just yucky or funny in the head. And most normal people will try to get off opiates as quick as possible. And one of the things we know about people who develop opiate and other use disorders is that their brains don't react like normal people, and the mood altering or the pleasurable response is very different for people that are predisposed to addiction. Other effects, opiates can cause nausea and vomiting, dizziness or drowsiness, constipation, respiratory stuff. So us addicts, we got to work through a whole lot of symptoms before we get to the euphoria, and it can be very, very calming. One of the things I used to do, well, my first training was in anesthesia, and I would meet people in the holding area, and they'd usually be pretty scared, and I'd tell them, I'm going to give you something to help you feel relaxed, and I would give the fentanyl through the IV, and you could see them relax. So it is pretty calming. And obviously helps with gets the anesthesia started. Overdoses are caused by a central nervous system suppression of the respiratory centers. And most recently we've been having more problems with fentanyl being mixed in with the heroin, which is very dangerous. Fentanyl is way more potent than heroin. Other problems that happen with people that are abusing heroin and other drugs is HIV and hepatitis and all kinds of diseases that they develop. One of the real issues with, need to stop that. One of the issues I think that happens with fentanyl addiction is called a stiff chest. And what happens is there's a reaction that occurs, not frequently, but it does occur in fentanyl use. And what happens is the chest wall becomes rigid. The chest wall muscles spasm to the point where people can't take air in or breathe air out. And it's not related to dose. It can be a relatively small dose. And when I was in anesthesia, I actually had that happen in a case. The case was a case that I was ventilating a person, so I had a mask and I was following their respirations with the ambu bag, and I'd given a relatively small dose of fentanyl. And all of a sudden, it was like trying to ventilate a brick wall. I squeezed the bag and absolutely nothing went in and nothing came out. And the person had a stiff chest reaction right in the middle of my operation. And fortunately, I had succinylcholine on my cart, which I immediately paralyzed the person and broke that reaction. But if that happens to somebody out on the outside and they don't have succinylcholine or at least naltrexone or naloxone, they're dead. I could not ventilate that person. So I think that's one of the reasons why we're having so many overdoses. Now, for people that have addiction, as I mentioned earlier, the real issue is that for people with the predisposition to addiction, the pleasure-reward areas of the brain just react differently to mood-altering chemicals. And the two areas of the brain that are most predominantly involved in pleasure and reward are the nucleus accumbens and the ventral tegmental areas. And those are the areas of the brain that have the highest concentration of dopamine receptors. And what we know today is that all of the drugs of abuse have a final common pathway that involve dopamine in the pleasure-reward areas. And what happens is, I'm going to back up a little bit and describe, we have normal pleasurable activities or things that happen in our life. If you go to your favorite restaurant, have your favorite food, it feels good. Or your favorite drink, whether or not it has alcohol in it, feels good. Sex feels good. Doing things with friends, those are normal things that normal folks have as pleasurable experiences. And what happens in the brain is that we have to have a certain number of dopamine receptors filled to feel okay, to feel normal. And if you go to your favorite restaurant, have your favorite meal, your brain says that feels kind of nice, and it releases dopamine. Apparently sex is twice as good as a nice meal because it goes up to about 200 here. And what happens in life, if something particularly pleasurable happens, we lay down memories. Everybody can think of times when they did something that was particularly rewarding or particularly fun, and they remember that. And what happens in addicts and alcoholics is when we put mood-altering chemicals in our pleasure-reward areas, instead of a normal amount of dopamine release, there's a tremendous amount of dopamine released. And we remember that. It's pretty powerful. I mentioned earlier that I was an anesthesiologist in another life. And I had been putting people to sleep and meeting them in the holding area, and they were pretty nervous, so I'd give them some fentanyl, and you could just see them relax. And young people would say something like, "Wow, Doc, what was that? Can I have some more?" So being the scientific person that I thought I was, I decided that it was my duty and obligation to experience what my patients were experiencing before I finished my training in anesthesia. Now, knowing what I know today, that's a pretty abnormal thought. Most normal people don't have that thought. And I certainly didn't have that thought about the neuromuscular paralyzing agents we use to keep you on the operating table. So I didn't try any Pavulon or succinylcholine, but I did want to try that fentanyl stuff. And I took home 1 cc, 1 milliliter of fentanyl. And we only know how to give medicines through the veins, so it was in a syringe. I told my wife I was going to go take a nap and shot up my 1 milliliter of fentanyl. Most relaxed I ever felt in my entire life. Now, prior to that, I had never abused anything. I wasn't a drinker. I grew up in a home where we went to church. Drinkers were sinners, drug addicts were bigger sinners, and I didn't do any of that. I studied real hard to get into medical school. But the next day, at the end of the day, there was fentanyl left on my card. And I was like, take it home or throw it out. Well, it was better than any wine I'd ever had. Took it home. Day after that, committee met first thing in the morning, and it was how much for the patients and how much to make sure I had left over. For me, it was that fast. Now, remember I said that I was going to experience what my patients were experiencing. Well, actually, I had a really good idea of what I was going to experience because that wasn't the first time I had a narcotic. The first time I had a narcotic, I was about 13 years old. I had what I now know was a migraine headache, and I was complaining to my mother about how bad my head hurt. And she had migraine headaches, and my dad was a doctor, so he prescribed medicines, and she went and got this little yellow pill and said, "Here, take this yellow pill and go take a nap, it'll fix your headache." Well, she gave me a Percodan at age 13. And I remember laying back in the bed, never went to sleep, going, wow, if I can have this for headaches, I'd like to have some headaches. So I had a pretty good idea of what it was going to feel like. And what happens in us addicts and alcoholics, this is amphetamine. That's 5 times more pleasurable than just about anything you experience in life. A tremendous mood alteration. And you better believe people remember that. Cocaine, 350. Morphine's every bit as good as sex. I think fentanyl is more like 350 to 400. But it's just, addicts have a different response to mood-altering chemicals. So what happens is we really like it at first, and then we really want to repeat that, and eventually we get to the point where we can't do without it. So our tolerance goes up, and our physical dependence and withdrawal symptoms increase too. And withdrawal really from opiates depends on the half-life of the drug. The longer acting drugs take longer to begin the withdrawal period, and it takes longer to get through it. Most of them, they peak in 36 to 72 hours. Heroin is a shorter acting drug. It has more withdrawal symptoms but lasts longer or shorter. And methadone is one of the worst to come off of. It can be up to 4 weeks that people are feeling awful. The people that sell buprenorphine try to claim that it's relatively short, but the patients we treat, that if they've been on Suboxone for a long time, taking buprenorphine, I think it's more like the methadone. They feel pretty bad for a good period of time. And the symptoms of withdrawal for opiates: nausea, vomiting, diarrhea, shakes, chills, sweats, cramps, ache all over, restless. What's it sound like? Nausea, vomiting, diarrhea, shakes, chills, sweats. Sounds like the flu, doesn't it? I've never ever had the flu that gets anywhere close to what withdrawal feels like. There's just no comparison. And the tremendous anxiety. The anxiety you really can't tell from generalized anxiety disorder or even panic attacks. Tremendous cravings. And the reason the cravings are so bad is you can stop those withdrawal symptoms in minutes by using. So tremendous motivator to use if you've run out and go get some. And one of the reasons that the drive to use drugs is so strong is the area of the brain that's being affected is the midbrain. It's the drives that keep you alive. It's the area of the brain that says you have to have fluid or you die. You have to have food or you die. Species has to have sex or it dies. But that part of the brain thinks it has to have the drug. And it's the same message. If you don't get your drug, you're going to die. And to get people to understand how powerful that drive is and how much, why people do the crazy, stupid things they do to get their drugs in the midst of withdrawal, I tell normal people to imagine that you were on a desert and you haven't had anything to drink in 36, 48 hours and you're trying to get off this desert. You don't have to stop and think to yourself, gee whiz, I'm thirsty. Your brain would absolutely scream at you. If you don't get fluid, you're going to die. And that's the same message that happens. I have been in withdrawal where it bubbled into my consciousness, if I don't get fentanyl, I'm going to die. Now, intellectually, I knew that wasn't true, but it felt that way. And if you were on that desert and came over a hill and there was a well with people all around that well drinking water, getting water, what would you do to get to the water? Anything it takes. And it's why us addicts will do all kinds of crazy things to get to their drugs that normal people wouldn't think about. And it's important to be able to make the diagnosis. Today in DSM-5 we have categories of severity. These are the symptoms: tolerance, withdrawal, using more than intended, cravings, trying to quit, can't. Mild is 2 to 3 symptoms, moderate is 4 to 5, severe is 6 to 11. To meet criterion for medication-assisted treatment, the diagnosis has to be moderate to severe. And one of the things that we find is that a lot of the people that we treat at Bradford have secondary psychiatric diagnoses. So anxiety disorders and mood disorders and actually personality disorders are real common among people that have had various traumas in their life. And one of the things that we also know is that most people don't start out with heroin. They start out with pain pills. A lot of times it's from family members or from somebody's medicine cabinet. And again, we have the problem of fentanyl being laced with the heroin. Okay. So this is kind of what happens with addiction. People use and it really feels great. and then they come back down and they want to chase that feeling again, and it keeps coming down. They keep chasing that feeling, but eventually they get to the point where they feel awful, horrible, terrible without the drug. And they're using to kind of get up to what they sort of remember was normal to function. And people can have unbelievable amounts of opiates in them, and they're walking, talking okay. For 9 years, I worked at 2 different treatment programs for healthcare professionals. I got all of the anesthesia personnel, and they could get to really big records. They could get up to 40, 50 cc's of fentanyl a day easily. You have to be creative to get that, but you can do it. And the first thing we have to do is get people detoxed. And in an outpatient setting, you would definitely want it to be at a place that does medication-assisted treatment so that you have time to slowly withdraw them. At Bradford, we do it pretty quickly. We get people off opiates in a matter of a few days, which means that they feel kind of rough, but we get them through that, and then we can move on to making other recommendations. And what we want is for all of the patients who have opiate use disorders to be on some form of medication-assisted treatment. And what we want to do is we want to keep them in treatment as long as we can. And once they're in our program, an inpatient, we want them to transfer into an outpatient setting. And there are 3 basic medicines we can use for opiate use disorders: methadone, buprenorphine, and naltrexone. And depending on which opiates have been used or what opiates we're using for treatment, they have different affinities. Affinity is how strongly attracted the opiate or the antagonist is attracted to the mu receptor. And the ones that have the very highest affinity are naltrexone and naloxone. And what they do is they occupy the mu receptor, but they don't do anything. So we have mu receptors. Normally opiates land and stimulate the nerve, and that's the feeling people get. And naltrexone lands on the same receptor, clamps on really tight, and doesn't do a thing. So if somebody uses, there's no place to land, and absolutely nothing happens. I actually was anesthesiologist, went to treatment for addiction, went back to anesthesia, and I was supposed to, shoot my drug of choice in people. And the only way I was able to do that was I was on naltrexone. And it turned fentanyl ampules into water ampules. They were worthless. They just, I was able to be in anesthesia, and the narcotics didn't even call my name. And, again, the naltrexone binds to the opiate receptor site. It's not addicting. If you stop it for some reason, there's no withdrawal symptoms whatsoever. It does not alter mood, and it absolutely takes the power of alcohol away, or opiates away. Some people also believe that it helps with alcohol cravings, and I've had some people that's true. As an aside, for alcohol, I really like to use Antabuse. I think that's a much bigger motivator not to drink, because I don't know too many people that crave throwing up. And we have 2 forms of naltrexone. We have pills that you would take every day, 50 milligrams, or we would transition them to Vivitrol, which is the shot that lasts for 28 days. And that's what we try to get everybody that's an opiate use disorder to do. We really want them to get completely detoxed, and we want to get them on naltrexone because it just makes early recovery tons easier. They don't have to make a decision. They're just not tempted to use. If they do use, they wasted their money. Now, if that doesn't work, if we can't convince them to do the naltrexone or Vivitrol, what we want them to do is either methadone or buprenorphine. And this is the same graph of how addiction develops. And then the people that want you to be on naltrexone or methadone, they're claiming that the medication keeps you kind of in the normal range without getting you real high or without you being in withdrawal, in kind of a steady state so you can function. And the idea is that you want to try to get the physiology back to as close to normal as possible, and in the meantime, try to get people to engage in the recovery process, and then reduce the signs of withdrawal and cravings. And there are two forms. The first opiate agonist that was used was methadone, and it's a full agonist, which means that it's more reinforcing. It hits the pleasure-reward area more. And since it's a full agonist, if you save it up and take a bunch, you can knock yourself off and overdose. Buprenorphine is what we recommend today. It's the modern day methadone. It's a partial agonist, so it doesn't have the mood altering characteristics that methadone does. And it binds not as strong as naltrexone, but stronger than the full opiates. So supposedly if you're on Suboxone and you use heroin or another kind of opiate, you're not supposed to be able to get it into the receptor. Now, we have some patients that will really try hard, and if you take enough, you can overcome that and knock it out, but you got to use a fair amount. The other thing that supposedly will happen is if you're on buprenorphine, or if you're on a full agonist, if you've been taking that and then go use some buprenorphine, it'll kick out that full agonist and you'll actually produce some withdrawal symptoms. Now, the real advantage of buprenorphine is the fact that it's a partial agonist. Any of the full agonists, you can overdose and stop your respirations and kill yourself. Buprenorphine, even if you use more than is prescribed, if you use a whole bunch of it, it has a ceiling effect. And basically, you won't stop breathing. The only way you can bump yourself off by overdosing on buprenorphine is if you add in some Xanax or another benzo or alcohol or something else that'll suppress your respirations, and then you can knock yourself off if you want to. Methadone, again, was first used, and we use it for people that we really can't trust to take home prescriptions of buprenorphine, and we send them to a methadone clinic where they basically have to meet people every day. They get a dose daily. It's much more regimented. They're followed much more closely, and they're not given more than initially a day's worth of medicine at a time, and it has to be taken at the methadone clinic. Buprenorphine we can prescribe, and we usually, what we do at our treatment program is we give them enough buprenorphine to get to their first outpatient appointment. And then when they get to the outpatient appointment, generally they're only given a week's worth of buprenorphine at first. And the deal is that you've got to stay in treatment, you got to go to your outpatient appointments, you got to do what they're asking you to do, or you don't get your prescription. And again, we start out with small doses for a week, and then it might stretch out to a couple weeks. But you know, we're doing it in a fairly controlled fashion, and it's much more safe for the patient. Supposedly, there's lower level of dependence. There's not as much euphoric effect. And again, medicine can be taken home and administered at home. Now, there are a couple different forms. Subutex is buprenorphine alone. We always want to prescribe Suboxone because it has two components to it. The buprenorphine is administered and absorbed through the oral mucosa. And in the oral mucosa, buprenorphine is absorbed, but the naloxone portion is not absorbed. However, if somebody tries to melt it and shoot it up IV, then the naloxone is absorbed or activated, and it'll actually put them into withdrawal. They'll not want to do that again. And again, the idea of giving people medicines to help them in their early recovery is we want them to finish our treatment program, enroll in an outpatient program, attend the appointments they're supposed to. They'll be at urine drug screen whenever they come for their prescriptions. We'll try to get the family involved, and we help them build up a recovery program to the point where hopefully someday we'll get them off, and they won't need that. Now, if we do transfer people off of buprenorphine, in an outpatient program, we can do that over weeks and kind of make it gentle for them. And then about 10 to 14 days after the last opiate, whether that's methadone or any opiate or buprenorphine, then you can switch over to naltrexone. If you do it sooner than that, you'll precipitate a withdrawal. It'll knock off any opiate receptor, opiate in any of the mu receptors. The other thing I'd like to talk about briefly is the overdose that we're having a problem with. The overdose deaths have just skyrocketed. There's essentially, basically 91 Americans that die every day. Every once in a while we hear about patients that, quit going to their program, quit doing what we asked them to do, and we hear that they died of an overdose. And what we do for all patients is that we prescribe naloxone, that all of the opiate use disorder patients. And we want them or their family members to have the naloxone. It's non-scheduled. Anybody can prescribe that. It's obviously not addictive, and it has a pretty rapid onset. Now, the bad news is you can only count on naloxone working for about 20 minutes, at the very most 90. So basically, if somebody is overdosed and they're not breathing, you give them a naloxone and you call 911. And that's what we instruct the patients' families. If you think your person is overdosed, then make sure that you have some naloxone and can administer that. And definitely prescribe the generic form. This form right here, that I forget which company has put this out. It's very easy to use, but it costs $3,400. But there's a deal for you. You get two. Yeah, I don't know. Yeah, I don't know. Do you think they're making any money? Anyway, so there are different forms. The nasal is probably the easiest way. This is an intramuscular injection that has instructions for it. And they say that they'll help you with the copay. So, have the naloxone ready to go. Now, one of the things that we talk to our patients about is the fact that if they have a period of recovery and they're not using any opiates at all, you really don't know where your tolerance is. And some people, the tolerance has decreased. So if they go back and use their normal dose, if they relapse and use their normal dose, they're in danger of overdosing. So we really warn people about that. Well, what about the folks that don't want treatment? Most of you guys, if you have patients that you suspect are abusing opiates, it's real hard to convince people in the midst of addiction that they have a problem. For sure, give them a prescription for naloxone. Do follow them up and try to make a referral to, give them the information for drug treatment resources, or a clinic that does the Suboxone or methadone treatment. A lot of times you can get people in the door going that route faster than you can get them into a program like Bradford's, where the goal is to get them off drugs. And for people that, we refer people to the buprenorphine clinics to prescribe the Suboxone or buprenorphine for opiate use disorders, you have to have the DEA X waiver. It's a specialized DEA number, and it's literally, instead of the first letter being, an A, it's an X, for example. And you have to go through a course to be able to do this. And when you see the patients, you're expected to do a PDMP search to make sure they're not getting opiates from some other source. When people arrive at the treatment program, they really need to have a medical and mental health history. They review all your medicines. They're supposed to have a physical exam. They do drug testing on a regular basis and laboratory tests. And again, to meet criterion for medication-assisted treatment, they have to be moderate to severe opiate use disorder. And then there are a number of resources that will help you if you want to have some handouts and resources through SAMHSA. That's what I have for today. Are there any questions anybody wants to ask?
What's your success rate?
What's the success rate? That's an interesting question. The real issue is that through the system that we have in the United States, almost no one gets adequate treatment. It's kind of like you wouldn't put somebody with diabetes in our treatment program for 3 weeks and tell them, don't have another bad sugar. And the statistics are directly proportional to how long you can keep people in treatment, whether it's inpatient or outpatient. And actually, the only people that really get adequate treatment are healthcare professionals. They're forced to have adequate treatment because we're held to a higher standard. And you have to prove that you're in recovery if you want to be a doctor and practice medicine. Not only did I work in 2 treatment programs that were specifically for healthcare professionals, I also was the medical director for the Alabama Physician Health Program. And I would not refer to anybody that didn't treat for at least 12 weeks. And then we would monitor those people for 5 years very tightly. And the interesting thing is I tell our patients, you feel how drugs make you feel in your body for a matter of hours. But it affects your frontal cortex for at least 4 weeks. Frontal cortex is executive functioning. You take in information, you process the information, you compare it to what you've learned before, and you make decisions. I tell our folks, if you got enough drugs and alcohol in your frontal cortex, you make bad decisions. But what that translates into is that for the first 4 weeks of treatment, people are still thinking like an addict. So most people are out the door, out of our program, before they ever stop thinking like an addict. And it's why we emphasize that you really need to do outpatient treatment after this. But when I was treating the healthcare professionals, I could count on halfway, right about 6 weeks, the light bulb would go on, and that by that time they would have stopped thinking like an addict and begun thinking like a recovering person. It was the last half of treatment that people really put stuff together and had a good recovery program going. So basically, it's if you don't treat adequately, you get bad results. And convincing people to stay in treatment's a real trick. Good question, though. All right. Anybody else? All right. All right. Thank you so much.